Hello.
Hello, hi. Can you hear me?
Yes.
Okay. Should I
Оксана, представте, будь ласка, конференцію.
Да.
Будемо починати.
Доброго дня, шановні
Good
колеги.
afternoon, dear colleagues. Good to see, and I'm pleased to welcome all of you here during these difficult times, but life goes on and our children need our help, besides the help on the high level. And today we start our 4th International Medical Online Conference on treatment of patients with Duchenne Becker's disease. This is the 4th conference, and actually our NGO and parent organization, professional organization gains new knowledge, and we want this knowledge to increase in the future. Let me introduce also Margarita Yashchenko, who is the representative of the NGO Duchenne Ukraine. So Margarita, the floor is yours. Please unmute yourself. Margarita, please unmute yourself. Sorry. Good afternoon. Good afternoon, Professor Yeremnevo and the participants of the conference. We're so grateful and thankful for all of you being here. As the mother of the child with Duchenne's disease, I always appreciate the attention around to these children and the doctors who work hard on the development of the medicine to help such children. I really appreciate all of this work. The situation in Ukraine is very difficult, and I want to inform you that if we have technical issues, I want to apologize for that in advance, but I hope that everything will go well today. And also I'd like to say that we have simultaneous interpretation, and everyone has the possibility to click on the panel of the screen, on the icon, the language you want to listen to this event in, either English or Ukrainian. Thank you so much, Margarita. Yes, we want to tell you that there will be the video recording of this conference because very few doctors have the possibility to be online because of non-stop internet disruption. I want to inform our colleagues about that as well, our speakers. And one more time, I'd like to remind you that you can choose the language, either English or Ukrainian, the one you prefer to listen to this conference in. And further, I'd like to give the floor to our dear colleague and guest, Professor Yoram Nevo, who has been supporting Ukraine for so many years, supporting children with Duchenne's disease, and participated at many our seminars about this topic. And this is the Professor Yoram Nevo, the head of the Institute of Neurology of Schneider's Children's Medical Center from Israel. Good afternoon, dear Mr. Professor. Also, the topic of your speech is the updates in gene therapy for patients with Duchenne muscular dystrophy. The floor is yours.
Okay. Good afternoon. Everybody's hearing me well? Is that okay?
Так, доброго дня, все добре чути, зв'язок є, дякую.
Yes, we can hear you well. Thank you.
Thank you for the invitation. We are going to talk today about the gene therapy in Duchenne muscular dystrophy. Maybe I can put my, is it okay that or can you change the slide, please?
На даний час Да. Презентація йде.
Right now, we see your presentation.
So this is my disclosures. I am PI in Pfizer CIFRO study. We'll talk a little bit about this study. And I was attending Sarepta Ad Hoc Advisory Board, and I'm PI in exon skipping studies in Israel. Slide, please. Okay, we are talking about gene therapy on actually what is called gene transfer. So what happens is that we take a virus in Duchenne muscular dystrophy. This is a V virus, adeno-associated virus, and we actually delete the natural viral genes, and inside we put a transcript, which is basically what we want to put is the DNA of dystrophin. Is that okay? The translation is, or should I stop for translation?
Так, шановний професор. Так.
No, we have simultaneous interpretation. Please go ahead. Yes, you can. Yes.
Зв'язок є, дякую.
Thank you.
Okay, so another slide. So here is the first problem, because the dystrophin gene is very large and it doesn't fit into the small AAV. Therefore, there is production of a mini and actually a microdystrophin. Therefore, the gene therapy in Duchenne does not result in cure, but hopefully will change eventually from severe Duchenne to very mild Becker disease. Slide, please. So when we plan, or these companies plan how to make this injected medicine, it contains three main components. One is the vector, the virus itself. The second one is promoter. Promoter drives expression in what tissue that we want. We want the expression to be in muscle disease. And the third one is the transgene, the DNA itself. And as we'll see, this is a bit different. Each of these components is different in different companies. Slide, please. So what happens is that we inject this treatment IV. It arrives to the muscle cell. It enters into the muscle cell. The viral tissue breaks down, and the DNA enters into the nucleus. In AAV, in Duchenne, the DNA does not incorporate with the human DNA, but creates an episome. So in parallel, there is production of the abnormal dystrophin of the patient and the new dystrophin that we injected. Slide, please. What we'll talk today is about the companies, or what we have so far, preliminary results of human studies in gene therapy. And basically, there are two companies. One is Roche Sarepta, and the second one is Pfizer, who are advanced. And we'll talk about another three other companies that basically that are a little bit behind, but we'll actually go into details in a few minutes. Slide, please. So this is actually how it looks, the construct in these five companies, and you can see that each is different from the other. So the vector is a little bit different. So let's say in Pfizer, the virus is AAV9, while in Sarepta, it's RAVRH74. Also, the promoter is a bit different in different companies, as well as this specific transgene, which means the specific DNA that will get eventually to the muscle. Slide, please. So we'll start and about the results we have so far, actually very preliminary results from all the studies that have been performed. We'll start with Rosh Sarepta, and please slide. Another slide, please. Okay, so in Sarepta, there have been so far 4 studies. Next slide, please. Next slide. Okay, so this is phase 1, or the first phase 1 study done by Sarepta. And phase 1 study, actually, the aim is safety, to see how safe is the medicine or what is injected. And actually, this is usually done in a small number of patients. So they did 4 patients. Even though the safety is the aim of the study, we really can see actually some effect. And we can see that actually after 3 years, these 4 children did well. We have to take into account that these are patients, young patients, age 4 to 8. And at this age, anyway, they are doing quite well. And the fact that actually this is very small number. Next slide, please. Again, next slide, please. Okay, what were the side effects? So the major side effect seen was that half of the patient had significant vomiting early on, and some of them had elevated liver enzyme, which actually all have been resolved. So not major side effect in this trial. Next slide, please. Next slide. Then they went to the phase 2 study. And in this study, they have 41 patients. And what they did is actually what will look in most of the gene therapy study, as gene therapy is just one shot. What they did is half the patient get the actually the medication in the beginning, and half got placebo. And 1 year later, the one who got the medicine will get placebo, and the one who got placebo will get the medicine. So after 2 years, everybody got the medicine, and we get actually data of 1 year of all the patients. And in each year, they have compared to the placebo. Next slide, please. So what did they learn from this preliminary study? First, in terms of safety, actually basically the same. What numbers of transcripts are entering each muscle cell? This is very important. So we can see that after 2 years, in each muscle cell, there was, or in much nuclei actually, there was something about 3.4 on average transgene, which is quite nice. And we expect dilution over the time, because there are dilution of the muscle cell over time, replacement. So this is quite nice results. In terms of the protein, we measure in Western blot, we can see that there was something like 40% of normal. Is the protein in the cell membrane? Yes, about almost 80% of the cell had dystrophin stain. And in terms of motor function, what are we doing is the North Star NSAA, which is a motor actually evaluation. And you can see that there was slight improvement. So at least, and we'll show basically in all the studies we have so far, we're talking about preliminary results, there is not a huge change. But if we expect to have even stabilization of the patients, we can see that as a major achievement. Next slide. All right. And then what happened is that Sarepta, after this, moved to another production of the virus. They did it on the lab, then they moved to actually commercial production, and they had to go back to do phase 1. So they did a phase 1 in something like 38 patients, again, looking for safety, different ages. Next slide, please. Again, in terms of safety, basically the same. Vomiting, elevation of transaminases. Next slide, please. What we can see, and this is something that this company presented of the first 11 patients that they had, we can see again that the protein, Western blot, was about 50%. Same in other method, immunofluorescent. Again, almost 4 copies, genome copies in each nuclei. Next slide. And if we look at the clinical endpoint, next slide, please. For this, they did a phase 3 double-blind when they actually recruited 120 patients. Again, half of them getting the injection in the first year, half of them will get it after the second year. This is fully enrolled. We don't have any published or presented data yet from this study, but we know, as I'll inform you, that they did submit the results to the FDA. Next slide, please. We don't have the results of the phase 3 study. What we do have, and this was presented by this company, is integrated results of all the studies before phase 3. And they pulled all the patients together. And what we can see that if we look at the motor outcome, the North Star, you can see that there was, after 1 year, improvement of, on the average, 2.3 points. And what they did, they compared it to external control. What is external control? There are some what we call natural history studies of Duchenne muscular dystrophy. So this is what is expected. Definitely, scientifically, this is not comparable to do a double-blind study, but it gives us a picture what is the course of Duchenne muscular dystrophy, and we can see that we get better outcome. This is also in time to rise from the floor, which was improvement compared to what we expect worsening, and 10-meter walk or run, which there is some improvement with treatment compared to what expected to have actually worsening over time. Next slide, please. So we move from Sarepta to Pfizer, and Pfizer actually had 3 trials. The third one, there's no results yet, it just started. This is actually treating very young people, aged 2 to 4, while other study, the phase 1 was 4 to 12 years old, safety, and actually the phase 3 study is 4 to 7 study. Next slide, please. Okay, this is the phase 1. So in phase 1, again, looking for safety of Pfizer, there was 19 patients. Next slide, please. So what we can see, I'll talk a little bit about efficacy and then side effects, because in Pfizer trial, there were side effects, and we'll talk about it in a minute. So what we can see in the results, if we look at the black, actually in the blue, this is the low dose, and the green, this is a high dose. And this is in the gray, what we expect to have, like external control. And we see actually that most patients on gene therapy doing better than what we expect from the natural course of the disease in terms of the motor outcome. Next slide, please. So this is showing the same. We look at a no-star. This is what we expect in 1 year from the control, and this is what we see from the patients in the phase 1 study. Again, few study, early age, but seem to be better results than the general outcome. Next slide, please. We can see that if we go into detail, we can see this in 6-minute walk test. In the elder one, we can see in forced vital capacity, in breathing. In those or a little bit elder age, you can see the pull, the upper extremities strength, and so all the functional assessment 1 year of post-therapy seem, let's say, in very, very preliminary results, seem to be better than in natural history of the disease. Next slide, please. So, therefore, Pfizer went to a phase 3 trial study. Again, the same, 2/3 of the patient in this case will get the treatment in the first year, 1/3 will get it after 1 year. And actually, next slide. So this is a double-blind control study. The primary outcome endpoint will be the no-star, so the clinical outcome. Next slide. However, we have to say that this trial did not yet recruit on patients, so we don't have results. And there were significant adverse or serious adverse events that happened in this trial. First, the one patient in the non-ambulatory cohort who actually died. And the result of that, the trial was stopped, and then Pfizer stopped dosing this population. In the preliminary, the phase 1 study, there was some acute kidney injury and thrombocytopenia, hemolytic uremic syndrome-like. And after this happened, the steroid dose in the trial was extended, and the dose was actually they given higher dose. And on the, let's say, so far at least in phase 3, we didn't see such actually complication. On the other hand, on phase 3, later on the disease, there were several cases of muscle weakness, myositis, rhabdomyolysis, and 2 cases of myocarditis. So if the first adverse event were related to antibodies to the virus itself, to the AAV, the second in phase 3 is probably related to antibodies to the dystrophin itself. And in most of these cases, they were for specific deletion. And the response to that was, after convening a expert panel, they decided that actually patients with deletions near the N and C terminals will not be treated with gene therapy. Later on, if we'll have some time in the question, we may address this issue. What is the rationale of this decision? So this actually study was stopped. Sarepta restarted dosing in the US, but in Israel, so far, we didn't get the approval to redose the patients. Next slide, please. Next slide, please. So I will talk very briefly now about 3 other companies. One is RegenX Bio, which hopefully will start treatment in the 2023, next year. Next slide, please. And they had unexpected problems in manufacturing, and there was delay in starting the trial. I mean, this is something we see a lot in these trials, that these are very complicated trials, very new one. So delay in beginning the treatment is very common. Next slide, please. Another company is Solid Bioscience. They actually started in 2017. They actually dosed 9 patients, ages 4 to 17. Next slide, please. They also, this is called the Ignite DMD study. They also experienced in 3 of them severe adverse effects. 2 of them were systemic inflammatory response syndrome and 1 thrombocytopenia. This is also the, at a certain point, this was stopped and then restarted. Next slide, please. All the events resolved, but still, Solid Bioscience has decided to stop enrollment in this study. They are now engagement with the FDA how to plan future clinical activities, and there is some rumors the company may be sold to another company and so on. So we don't know at this point what will be the route of this company. Next slide, please. So the last one is Geneton. Geneton is a European, and they started in a different way. They actually, the first part is recruiting 100 patients on a baseline study, just follow-up of the study, and then dosing these specific patients. They had 1 serious adverse event in April 2021. I couldn't find exactly what it is, but it was stopped, and they are all planning to start very soon again redosing. Next slide. So summary of all we have. So we have only very preliminary results. All the results we have are provided by this company and presented in scientific meeting, but we don't have manuscripts in journals. So actually, this is not actually had the referees look at them. There is submission of Sarepta to the FDA. Hopefully, if that will pass, we'll have a medication. There are differences between different companies in these 3 components, in the virus, in the promoter, in the transgene. So maybe potentially different in effect and maybe potential difference in safety. So we'll have to look for it. Not all patients may be included in the study, so most study now will not include patients with deletion in the NC terminal. Other patients who have antibodies to AAV, so many patients have natural antibodies to AAV, at this point are excluded from these studies, and the companies are working very hard to try how to clean the antibodies, how to be able really to treat those patients, but it's at this point it's not possible. And treatment actually is associated or may be associated with severe adverse side effects. So this is something that the patients should understand, that there are hope, but still there is some danger in entering at this point of trials of gene therapy. So if we have to summarize this in one patient, we can say that development of AAV gene therapy is still, I think, today the most promising strategy we have for Duchenne muscular dystrophy. But there is some risk, and we are still in the learning curve. So I thank you for your attention. Next slide, please. And I would like to thank all my team who are working with me. As you know, it's not a one-man job, and we have to have a really huge dedicated team to be able to manage and treat patients with Duchenne muscular dystrophy. And so we have some promising options for the future, and we really hope that these will bring us much better news in future years. Thank you very much.
Дякую, шановний пане професору. І якщо можна, в мене є деякі запитання, чи можна вам задати?
We have a few questions. Can we ask you these questions, dear professor? Dear professor, we have a few questions. Can we ask you?
Шановний пане професору, в нашому
Dear professor, in our Zoom link,
Professor Nevo, you can change translation.
I can just this translation. Let me
To
see.
English.
Interpretation. This is
Yes.
English. All right. Thank you.
thank you so much for your speech, dear professor.
Thank you.
Thank you so much for this wonderful presentation of the future, Professor Nevo. And given the fact that most children, most families are waiting to receive the new therapy, modern therapy, and they want to receive more or less specific date or year. In your opinion, how much time will it take for the companies, given that you run these researches and you see how effective these medications are, on what stage they are? So could you tell us when in the world we will have the access to these new medications?
Okay. First, it's very hard always to predict, but the most, or let's say the closest to get actually approval are now Sarepta. So Sarepta and Roche actually submitted to the FDA requests for quick approval of their agent. So if that's the case, we may have approval in something like July or something, or I think something when such request is submitted, there is something like 6 months usually the process of the FDA to give their answer to. I'm not sure what will be the answer of the FDA, if they will approve it or will ask for further information, as we are not aware actually what is the final results of their phase 2/3. I guess they are optimistic because they submitted it. That it is not necessarily the fact that they will actually get the approval. Also, if they get the approval, one of the other obstacles that we are facing is the fact that there will be a huge demand of this medication. And I guess that being an American company, they will start probably in the US. So until we'll get the medication, somewhat later. So maybe a year later, maybe a little bit even more. There's supposed to be production of this AAV and transcripts, etc. And the third one, the third obstacle will be probably the cost of the treatment. We're getting now more and more gene therapies and more very expensive therapies, and in the cost that a regular human being cannot afford that. So this is an issue of government and to get this. In Israel, it's called in the basket, to be included in the basket. But also, let's say if we started with SMA, which was the first disease that actually got a very effective treatment, this was included in the basket. But now, if we'll get more and more of this treatment, it's getting more and more to the country's economic to afford that. But let's hope that I think we'll have to go step by step. I think what we have to hope is that this will be approved and we'll have a medication in let's say, within the next year. And then we'll have to look for all the practical issue, how to get it as fast as we can to our patients.
Дякую за відповідь,
Thank you so much for your answer, dear professor. And there is one more question. Let's talk about the medications that Sarepta company is preparing to produce. What dysfunctions?
Dysfunctions, if you
And
mean,
there is no other voice. So I think we lost the connection with the speaker. Sorry.
you lost
I cannot hear what she's saying. I can hear what you're saying and everybody else, but I cannot hear what the speaker is saying. Something is wrong with her internet connection. So we'll have to wait. Sorry.
Okay.
I'm sorry I had the internet connection, the speaker says. And could you tell us, please, for our audience, because it's not just the doctors who are listening to us, but also patients and families, Sarepta company, what kinds of dysfunctions, what enzyme dysfunctions will it be effective for, so that our listeners would understand who has a chance to receive the fastest treatment?
Dysfunction, I guess the meaning is what we can expect as side effects, right? And the most common side effects we can see, or we saw in Sarepta trial, as I mentioned, were mainly those of vomiting. So many of the patients have vomiting, and some had to be hospitalized and watch for that. And some had actually elevated liver, so some kind of a liver injury, but they were all actually temporary and treated actually very well. The question is that, as we saw with other gene therapies, that what we may expect is we may see immunological side effects that may be related to the virus itself. And we may see actually immunologic effect related to the dystrophin transcript itself. Actually, let's say that these are, even though that we should expect that they may happen, I think still in Sarepta, we've seen actually less than we saw a little bit with Pfizer at this point. And so eventually, even with Pfizer, we think that it's still rare. And the fact that first the steroids now have been increased, and the fact that some of the patients who are more at risk are now excluded from the program, we really hope that we don't have severe side effects. But still, this is something that we'll have to look to see in the future. Hopefully, we'll have, by this management and precautions that are taken at this point, we'll see the effect with, let's say, minimized side effects.
Дякую. І
Thank you.
відповісти на питання.
And could you answer the following question, please? What exon disruptions could be the indication for the use of Sarepta medication?
Great question. I'm not sure I have the list here. Let me see if I can have it. I'm not sure.
Шановні колеги, якщо у вас є запитання, ви
Dear
можете
colleagues, If you have questions, please write in the chat or raise your hand, and we will give you the floor to ask the question.
It's a good question. I don't have it on hand, but we'll actually send you later on the
Да,
exact.
ну це питання майбутнього, коли вже буде препарат.
That's the question for the future when this medication is available, of course.
Right. Yeah. But yeah. I mean, there is some. This is. I mean, there's some difference between the company which is related to the dystrophin manuscripts. So the thought is, and maybe this is more interesting than the exon itself, even though for the families it's very, very. They want to know actually if their child can be or cannot be included in the study. So we'll try to find out from Sarepta exactly what the exons are. But the idea is that even those who have Duchenne, they don't have zero dystrophin. They have very, very small amount of dystrophin. And if they have this small amount of dystrophin, our body can recognize this dystrophin and does not produce antibodies if we put external dystrophin with exactly the same. But if we have, let's say, Duchenne that misses some of these exons, and these exons are present in the transcript of the gene therapy, there may be immune reaction towards this protein. That's why and because of the transcript has some part of both the beginning and the end, what we call N and C terminal, these are for precaution is actually excluded. This is the idea. I think they have published these exons that are excluded, and we'll try to look for their publication.
Якщо можна, в мене є питання.
I have a question, if I may.
Yes.
Дуже багато питань від батьків стосовно...
There are a lot of questions from parents about vamorolone.
Чи продовжується дослідження по
Is this
препарату?
research on vamorolone continues about this medication? Because we know that there are fewer side effects in contrast to corticosteroids. And are there patients in Israel who constantly take vamorolone? And what can you say about this medication? And does it help children?
Okay, so we are now moving from gene therapy to vamorolone. So vamorolone is not gene therapy. It's a new type of like steroid, actually. This is actually, I think, also submitted to the FDA. So hopefully this will be a medicine that can be obtained. So far, it is not a medication anywhere in the world. We participated in the study of vamorolone. So I think we have 8 patients treated with vamorolone. And in some of them, we could see, I mean, I think this has been published. I mean, there are some publication about vamorolone. The advantage of vamorolone is that many of, or some of these patients, first, their height is not limited, so they are not very short, as we can see with other steroids. Some of them do not gain weight, but not all of them. Some of them did get weight. And there are some improvement in bone metabolism in those patients compared to other patients. So yes, we think that vamorolone is a steroid with less side effects that we see with compared to, let's say, prednisone or the Flazicort if you use the high doses. And we hope that they will be in the market shortly. Yeah, I think hopefully, yes.
Мгм. Дякую. У мене ще таке
Thank
питання.
you so much. And I have one more question. As a scientist, as a doctor, of course, you prescribe the treatment. And in your opinion, does physical therapy help and to what extent?
Okay, so let's say what we can expect and what we don't need to expect. Let's say what we don't need to expect from physical therapy. Physical therapy cannot produce strength. So it doesn't counteract the disease itself. But physical therapy in the early stages and hydrotherapy in the later stages, if it's important to counteract or to prevent complication of the disease. Let's say in the beginning, the fact that we can actually prevent contractures, let's say of the Achilles tendon, actually helps the children to walk longer. And this is important. This is very important. As long as the children walk more, they can keep their back straight and actually deterioration of respiratory. So this is important. Also, it is important to have the patient active, not too active, not to do exaggerated work, but being active, walk, being able to do things is important to keep them. And I think this helps the disease. So on the other hand, when, let's say, when patients are non-ambulatory, and then for the lower extremities, you cannot actually counteract the contractions unless they are painful or actually this is debilitating and doesn't help them to sit properly or lie properly. But then the function of upper extremities is important, to work on the upper extremity. In later stage, definitely physical therapy of the respiratory physical therapy is very, very important. So yes, I think that the treatment or physical therapy is very important. And in addition to that, the physical therapists help us a lot in measuring. So if we need this 6-minute walk test, the North Star, this helps us very much to know the course of the disease and the course of the disease, and help us all the clinical trials to see if our patients are actually improving on this. If you will excuse him, just one last question, please.
Дякую. Дуже дякуємо за вашу участь.
Thank you very much for your participation, for your support, and we hope we will see you later.
Дякую.
Okay, thank you very much.
Дякую.
Keep you all safe, and let's talk in the meeting next year.
Дякую. До
Bye-bye.
побачення.
Thank you very much.
Bye-bye.
Шановні колеги, ми продовжуємо з вами.
Dear colleagues, we will continue our program, and the next report was supposed to be by Tsarenko, але since due to the internet disruptions, the speaker couldn't connect to us, so I kindly invite Professor Natalia Volanska, who is helping so much to all children with digestion disorders and eating disorders. And I would like you, Mrs. Natalia, to introduce yourself, what you do, where we can find you for consultations, because for patients it is very important where they can go to cope with their problems with eating disorders. Thank you very much for the invitation. I work in Ahmadit, in a polyclinic, and I do my best to provide our patients with help, those patients who require urgent assistance. And also my major goal is to improve the health of bones. Can you see my presentation on the screen? Yes, we can. I apologize, I'm a little bit nervous. So all the patients who need help, please, you can come to us to Ahmadiyat Polyclinic. Today, I would like to speak about the problems with nutrition, nutritional status with DMD, and regarding the problems which we have is the loss of weight or excess weight. And later on, we can talk about this. For example, there is patients with obesity or with other disorders, and the nutrients balance is disturbed. Also, very often patients, especially adults, have problems either with due to this obesity or due to certain need of assistance during lung ventilations. They lose liquids and next liquids in the body, and then the next complication which negatively affects the way the quality of life is osteoporosis and complications. What are the causes of such disorders in patients with DMD? This may be a problem with eating, for example, that the patient might need gastrostoma or zoned nutrition. Also, the lower jaw bones and contractures of lower jaw bones aggravate and complicate the intake of food. Also, the administration of glucocorticoids can cause obesity, and also the patients with Duchenne disease, when due to immobilization, they have loss of energy and there is a disbalance. A child can get the same products and food as before, but then the loss of energy is less. So this may be a cause of obesity. And another common cause is immobilization, which leads to the fact that a child is quite not active and cannot cannot just easily stand up and walk to take some food to eat. When today's trials show that the cause of obesity with Duchenne in patients with Duchenne disease might be is not determined yet. This may be due to the lowered activity, or maybe with the problems with the also there is with metabolic disorders. Also, there were several trials whether the basic energy need of children with DMD are lower or higher than in normal kids. And we can see that there are two trials who studied basic energy exchange and energy turnover. And it shows that patients, 310 patients with DMD, they have higher basic energy exchange. The patients were from 11 to 29 years old, and this basic energy exchange increases with age, while patients who already have mechanical respiration support, they have lower energy need compared to healthy people, and we calculated this need according to the Harris-Benedict formula. Based on the recommendations which I found, it is recommended to calculate the general energy need according to the formula basic energy need multiplied by the rate of physical activity. But this is only the primary number, and then it is important to monitor the body weight and then decide whether this number is sufficient, or the number of kilocalories is sufficient, or, for example, a child has excess weight, and then you can already correct the nutritional status of a patient individually. Today, there are already the basic indicators of energy in children, or we can calculate the formula with where there is age, weight, and gender, and also the activeness rate, because if a child is in lying position all the time, the coefficient of activity rate is 1%, is 1, and for sitting position is 2, and for walking children is 1.4. What are the needs in nutrients and microelements and vitamins? Of course, these patients with DMD, they need to have control of vitamin D in their blood. If they have an optimum content of vitamin D or insufficient, they have to take vitamin D. And if there is a vitamin D deficit or a severe deficit, there are doses which are prescribed to such patients daily for 3 months. And after that, there is they determine the level of vitamin D in the blood again. If there is the optimal level up to 60, more than 60 nanogram per milliliter, it may be enough. The dosage of vitamin D up to 4,000 is international units is enough for patients with severe vitamin D deficit. If a patient is administered with glucocorticoids, he or she should also take calcium medications, 30 to 50 milligrams per day, such as the dose, or it is possible to prescribe 7 and it is very important to prescribe combined medications, calcium and vitamin D together in one. Also, regarding the anthropometrical data of DMD patients, the height of the DMD patients is lower by 1.5 to 1 cm compared to the peers. Also, it is ascertained that such patients, the deflazacort have glucocorticoid, cause these growth indicators lower compared to those who do not take them. And it's very difficult to measure height in teenagers who already have scoliosis and contractures. So we recommend, it is recommended to evaluate the length of the upper extremity and in order to evaluate the height of a patient. Regarding the body weight, we also have very interesting results. The first results by McDonald that show that the patients from 9 to 13 years old have obesity, while the age over 17 years old has already 65% of them have body mass deficit. Before puberty, there is an inclination to obesity, but older kids already have an inclination to body mass deficit, body weight deficit. And the trial showed that in the age category, the Wheeling trial showed that in the age category of up to 13 years old, the deficit of body mass was in 54% of boys. So in such a case, we use if the index body weight index is difficult to measure, we use other indicators. Currently, there are normative charts for body weight of patients with DMD. We are not supposed to use the national diagrams for such patients in order to interpret whether the body weight is normal or not. But the national anthropometric diagrams are very important in terms of longitudinal monitoring of patients, because they allow us to monitor and see how a child is developing, whether the weight is increasing or on the contrary, it is decreasing. So the evaluation of the body structure, body build, is a very efficient tool to measure the status of DMD patients. If you see the problems with, for example, evaluating body weight or height and skin, but now there is also other methods like MRI and DXA, and they enable us to evaluate the body build and the fat content in body. This method enables us to evaluate the level of fat in fat weight in the body, and also by separate parts of the body. And this method also enables us to evaluate non-fat mass weight. So this basically shows the scope of muscles in a patient. These studies are very promising for DMD patients. Also, this densipometry enables to evaluate the dynamics to see how the fat mass decreases or increases, and what is the dynamics of muscle mass or fat mass decrease. Obesity arises because there is lower in mobility, and this means that the decrease of the
It has a negative impact on the muscle tissue because there is the contraction of the muscles. Also, obesity has a negative impact on the breathing function. As usual, patients have higher frequency of breathing. Also, obesity has a negative impact on psychological development, complicates the development in general, especially the second and the third type of obesity. And also, I would like to say that corticoids increase the volume of subcutaneous tissue, and corticoids have a positive impact on the muscular tissue for the patients with Duchenne. And also, we have to balance nutrition for patients with Duchenne and decrease the percentage of the fat tissue, and that will have a positive impact on the muscular tissue. And the saying we know, eat less, move more, will decrease obesity. With Duchenne disease, it doesn't work. We have to keep that in mind, because the negative energy balance, I mean, when the child starts limiting himself or herself in food, it leads to the decrease of the muscular volume as a result of the nutrient deficiency. And of course, the child will have no possibility to recover that muscular tissue. And the influence of different diets to muscular and fat mass showed that healthy people who limit themselves in food lose 70% of subcutaneous tissue, but 30% loss of the muscular tissue, which does not recover later. That's why here we have to balance nutrition for these patients to prevent the obesity and this way not to have an influence on the muscular volume. What are the reasons of the decrease of the muscular volume for children of older age? First of all, reduction of mobility, limitation of self-nutrition. So if the child is on the wheelchair, the child may have problems related to getting some food. In terms of the disease progression, and there is the decrease of the movement of the neck and head position, and also the wrong help from the caregivers and the decrease of the cognitive functions, the problem with opening mouth or chewing the food, and the episodes of choking, since it causes fear for the patient, and the patient may have fear during the next food intake to eat hard food, and the patients start eating soft food, but the change of the texture of the food which is grated decreases the nutrients because the grated food has fewer nutrients and fibers and so on. So the color rash of the grated food in contrast to the food which was not cut on the grater is different. So this triggers lead to the development of the deficiency of the body mass. And in this case, we have a different tool. We can put gastrostome, which will enable the patient to receive necessary calories and avoid the deficiency of the body mass. But it's important to put gastrostome before respiratory dysfunction and disruptions appear, since it may lead to the problems with anesthesia during the gastrostome placement. It's recommended to put gastrostome at the age of 19 or 22, from 19 to 22. And the next trigger, depending on the nutrition, is the quality of the bone tissue. Patients with Duchenne have osteoporosis as a rule, and the development of it is influenced by progress in muscular weakness, since there is the correlation with the muscle and the bone. And also the next trigger is immobilization, which triggers the cascade of the resorption of the bone tissue, and the patient loses the bone mass very quickly. And it's possible to lose up to 30% of the bone mass during immobilization. Also, inflammatory cytokines, which are usual with Duchenne dystrophy, will lead to increased resorption of bone tissue. Apart from that, corticoids, glucocorticoids, have the impact on the structure of the bone. On the one hand, it decreases the number of osteoblasts and the formation, and on the other hand, it increases the resorption. And the third effect is the decrease of absorption of calcium in the intestine and increased metabolism of vitamin D. Apart from that, the patients with Duchenne have the deficiency of vitamin D, since they have the lower insulation. And all these triggers lead to the fact that the patient has low bone density, and it leads to osteoporosis. Natalia, you have a few more minutes, and then please, you'll have to finish. And also you can see that the frequency of bone fractures is very high for patients with Duchenne, but I also want to say that vertical fractures are very usual for such patients. They may be the first ones, and it may signal osteoporosis. That's why the patients who have Duchenne, it's important for them to run densitometry and genographics in the side projection. If the patient has the pain in the backache, then X-ray of the side projection should be done during the acute pain, or if we had this X-ray planned once in 2 years, we have to do it more frequently because it enables to identify the fracture. Right now, we can treat the patients with osteoporosis with Duchenne when there is at least one fracture, not necessarily vertebral. And right now we have the medications which have proven to be effective with Duchenne disease. And there are two medications, pomedrone acid, and it's decided with the patient what medication should be used, and this therapy may be up to 2 years. And then it's important to decide to stop that therapy or to continue the support and assistance therapy. Thank you for your attention.
Thank you very much, first of all, for your kind invitation to be part of this conference. I'm very pleased to be here. I'm very honored to be here with you because, of course, all the scientific and clinical community is with you and wants to provide you all our support. My name is Giovanni Paranello. I am based in London. I'm associate professor of pediatric neurology at UCL and Great Ormond Street Hospital. I was trained in Italy, actually, as you can easily imagine from my name. And then I moved to the UK in 2019. And here I'm involved in management of and diagnosis of children with different neuromuscular conditions, in particularly children with the Duchenne muscular dystrophy, spinal muscular atrophy, and other conditions. And I'm also involved in clinical trials to find a treatment for these neuromuscular disorders, including Duchenne muscular dystrophy. So what I will try to do today is to share some of the guidelines to manage Duchenne muscular dystrophy, but also try to give you some more of our experience, in how we manage these patients, and also to give you some very recent update on how we are slightly changing, our approach, our multidisciplinary care of these patients. I will share the screen now. Is it okay that I start?
Так, будь ласка.
Yes, please do.
So I hope that I will not repeat something that has already been said today by my previous illustrious colleagues, but just to say that essentially we have now demonstration, compared to the past, that if we have a very proactive management and also an anticipatory management, try to anticipate the onset of side effects or comorbidities in this condition, we can significantly change what is the progression. So, for example, you can see here the dramatic change that we have seen after the introduction of spinal surgery or the non-ventilatory, non-invasive ventilation in prolonging survival in patients with Duchenne. And then the implementation of the steroids also helped in prolonging ambulation and also delaying death. And of course, this is very, very important because we know that already by doing this without any treatment, we can significantly affect what is the trajectory of this disease. And I'm sure that you are very familiar with this picture showing that essentially a number of processes and professionals are implicated since diagnosis, since the first meeting with these families and with these patients, in order to provide to them the best available care. You know that there are different stages of the disease, from the early ambulatory to the late non-ambulatory, and for each of these stages, we now know from the standard of care that we can put in place several approaches, either on neuromuscular management or on rehabilitation, endocrine, cardiac, respiratory management that can improve the quality of life of these patients. The first aspect that I would like to remark is that early diagnosis is important in this condition. Unfortunately, I'm not sure, I'm sure that in Ukraine, you know, doctors are very good in early detection and early diagnosis of patients with Duchenne muscular dystrophy, but this is a very important aspect, because of course, the early we start the management and you know, the treatment whenever possible, the better would be the outcome on the long term, because we still see patients that are referred to us still when they are a little bit older, you know, than expected, like 6 or 7 years, because they have been misdiagnosed, or they have undergone other investigations, like, for example, liver biopsy when there was increased transaminase, without suspecting that that could be related to a neuromuscular problem like Duchenne muscular dystrophy. So early genetic diagnosis is very important. It's very important also the counseling that we give to the families. We used to provide the testing for the carriers and prenatal and testing as well to the families. We will see that we have some approved treatment here that we try to start as soon as possible. We try to provide support to family immediately after diagnosis, connecting them to the advocacy groups. We have several advocacy groups and charities here in the UK that provide a lot of support, a lot of material, a lot of leaflets, you know, and counseling to especially to the newly diagnosed families, because it's very important to be very well oriented on what to do, because of course this is very traumatic, you know, for every newly diagnosed families. In terms of neuromuscular assessment, we used to see patients every 6 months, and you see here a number of assessments. So of course, physiotherapy assessment is one of the main aspects that we try to focus on, because we want to optimize muscle strength and function. We want to promote participation and access to education for these children, you know, when they grow up. We provide wheelchair service whenever possible, you know, manual wheelchair or a power wheelchair when they lose ambulation, of course. We provide orthotics review and recommendation. And of course, we organize all this multidisciplinary management, including dietitian, cardiologist, pulmonologist, the endocrine professionals, orthopedic, and so on, because we know that this is very important. The North Star assessment is one of the main functional assessment that we use in clinic, of course, and this is now used not only in the clinical setting, but also in the clinical trial to monitor the progression of the disease and also to capture very early signs of a possible efficacy, you know, when there are treatment that are under investigations in clinical trial. And we are now trying to develop some pictures or centiles that are also easily for the families to understand and to monitor their child, you know, every time that they come to clinic, to understand as their children progress, but also what we can do as long as we notice some deterioration with time in some of these items. Corticosteroids management, of course, is crucial and is currently the only treatment that is somehow part of the standard of care. Prednisolone was the first one that was initiated in the North Star network, which is the network here in the UK that links more than 20 clinical centers for neuromuscular patients. But then over the years, also the Deflazacort have started to be use, and I will show you why. And the data that we have. And I will mention to you later on some of the very recent data.
Дівчата, два переклади. Два переклади.
Sorry? The translator?
Робите. Sorry, it was some moment, but it's okay now.
It's okay. For the steroids, for example, we have seen, while in the past, it was recommended to start steroids when there was a sort of plateauing or a decline in the motor abilities. We now tend to start much earlier, let's say after the age of 4 years, because if we start a little bit earlier than 4 years, there is still not clear agreement about the safety of starting so early. But definitely we don't expect to achieve the plateau or the declining phase. And if we have children who are already diagnosed at the age of around 4 years, we tend to start the treatment, because we have seen, for example, from this paper, that the children who started before the age of 5 in the continuous line here were the ones who had a better outcome on the long term. But of course, corticosteroids have a constellation of side effects, as you see here. They are, of course, associated with the positive effects like improving in energy and motor skills and delaying loss of ambulation and cardiac and respiratory decline. But on the other side, of course, can be associated with weight gain, hypertension, osteoporosis, decreased growth, and so on. And so it's very important that we monitor closely, especially in the first 3 months after starting, but then every 6 months, all the possible side effects. So we monitor weight and height, blood pressure, glucose, bone health, and all, the other possible comorbidities. And as soon as we notice, the occurrence of these side effects, especially in terms of worsening of behavior or worsening of overweight, we tend to adjust the dose accordingly. But you should bear in mind that there is a minimum effective dose, which is considered 0.3 milligrams per kilograms in prednisolone treated patients. You have already heard about bone health in the previous presentation. Just to say that usually we try to provide 1,000 units, and this is sufficient to maintain high levels of vitamin D. We usually want to stay around between 75 and 100 of 25-hydroxy vitamin D in the blood. And we monitor as well with the DEXA and the lateral X-ray if there is a decrease in the bone mineral content, and also signs of vertebral fractures, which is the shrinking essentially of the vertebral bodies. And the previous speaker has already mentioned about this. It's important because now the way in which we approach this is slightly changing. We try to, because we know that this is quite common, we try to flag up this quite soon. And for example, we always inquire from the patients if they have pain in their spine. We touch the spine to feel, especially in the lumbar region, if they feel pain, because this might be a sign of a vertebral fracture. And if there is a vertebral fracture or any other fracture, and if there is reduced bone mineral density below 2 standard Z-score on the DEXA, this is an indication that our endocrinologists consider to start bisphosphonate treatment. Several studies have shown that improves the bone health of our patients. In terms of cardiac management, again, we also have the standard of care guidelines, we have now become much more proactive as well. So we try to monitor patients every 2 years before the age of 10 years, and then at least once a year after 10 years. And now we tend to start after 10 years, both AC inhibitors and beta blockers immediately after 10, 12 years, even if there are no sign of cardiac impairment on the echocardiogram. And there is recent evidence also that later on in life, another medication like spironolactone or eplerenone can be associated with this medication, because some preliminary studies have shown that this may be effective in protecting the heart. Respiratory function also needs to be monitored. And you see here that the risk is particularly high for non-ambulant patients. But we have shown that corticosteroids, compared to being naive from steroids, somehow protect the respiratory progression, the respiratory function deterioration with time. It's very important also to understand the connection between respiratory management and cardiac management, because we know that patients, even if they have a normal sleep study, they may struggle to maintain a good respiratory function, and sometimes even starting when they are non-ambulant, even starting non-invasive ventilation, especially when there is, for example, signs of weight loss or signs of nocturnal hypoventilation, is helpful to protect the heart as well, because of course patients who are not ventilated may struggle more in maintaining their respiratory function. As soon as patients start steroids, we provide an emergency care plan, because we know that steroids can be associated with adrenal suppression. So it's very important that families are aware that patients are at risk of adrenal suppression if they get an infection or if they need a surgery. So we inform family, we educate family to provide additional hydrocortisone if the child is unwell or if the child needs to undergo a surgical procedure. We provide anesthetic, risk indications, of course, and there is also these issues of heart embolisms that may happen after bone fractures, and these are the signs, you know, to capture early signs of heart embolism for a child, for example, that has experienced falling from a wheelchair or having even a minor trauma, because this could lead to death if not properly detected and managed, of course. Now I want to spend a few words about how we are changing our approach to corticosteroids treatment, because of course in the past there were, and I will show you in a little bit, there were different approaches. You know, we had the intermittent steroids regime, mainly 10 days on and 10 days off. We had the daily regime every day. We had prednisolone 0.75 milligram per kilogram, or the Deflazacort 0.9 milligram per kilograms. But there was not, and there is not still, a clear consensus on which type of steroids to use and which regime to use. So we had here, to our help, the 4DMD study that essentially was designed as a proper clinical trial for children who were steroids naive between the age of 4 and 8 years. And these are the 3 years data results that have been published this year. So you see that essentially in the green line, you see intermittent prednisolone, and in the red and in the blue line, you see the daily prednisolone and the Deflazacort. And at the end of the 3 years, you can easily see here that the daily regimes, both of them, showed similar results in maintaining. This is the time to rise from the floor, which was the main motor function assessment, compared to the decline that we have seen over 3 years in the intermittent prednisolone regime. So in terms of efficacy, both the medications in patients who were completely naive from steroids show similar efficacy compared to the intermittent ones. But of course, this was also associated with a different safety profiles in terms of side effects. So you see here that, for example, the daily deflazacort was associated with less gain in weight compared to both intermittent and daily prednisolone, while deflazacort was associated with a worsening of the height, and we know that these children grow shorter if they are on deflazacort compared to the daily prednisolone and the intermittent prednisolone. We have looked very recently at the data in the North Star registry. We have more than nearly 800 patients in our registry with Duchenne, and we had looked at the difference in the trajectory of their growth in terms of height on the left and weight on the right with the different regime. So the yellow is the deflazacort intermittent, the orange is daily, the red one is the naive, so patients not on steroids, and then the prednisolone intermittent is blue, and the green is prednisone daily. And you see here that if we look at the height, essentially the daily deflazacort, of course, not surprisingly, is associated with the higher growth stand, so the patients grew up shorter than the ones of prednisolone. But if we look at the weight, both prednisolone intermittent and prednisolone daily, which is the green line, was as compared along with the deflazacort daily, were associated with a higher weight gain, but the prednisolone in particular was associated with a higher weight gain. We see here the age starting of the overall North Star population that we have here in the UK. You know, the median is 5.85. This is 5 years, so nearly 6 years. This is why I said we should try to start even earlier. And this is the change over the last 10, 15 years. You know, at the beginning, we prescribed much more in the past prednisolone, but then over the years, also the deflazacort became available, and we started to prescribe also the deflazacort. In terms of the regime, you see that intermittent is still quite common, but now daily is becoming much more common. And we also still have some, but much less than in the past, some weekend-only regimes in a very, very few cases. This is in terms of the dose over time. You know that for prednisolone in red, usually should be 0.75 milligrams per kilos, and for the deflazacort should be 0.9 per kilos. And you see that, of course, there is, while we try to maintain quite high the dose, you know, close to what is recommended in the early ages, then there is a progressive decline because we tend not to adjust the dose, especially because we know that this is associated with side effects. We try to limit the side effects. And this is a graph that shows over the year how we have tried to lower down the age at which we start steroids, which was much higher, you see here, around 8-9 years, and now is, as I said, around 60 years of age. And this is the time between the diagnosis and the age started treatment that is also going down slightly. This is the first glucosteroids prescribed in the first year starting steroids. you see that while in the past it was mainly prednisolone, now also the Flazacort, and we try to start much more commonly with the Flazacort. And here is which is the regime. So there is 50-50, I would say, when we start the prescription between daily and intermittent. Just to have a look at the switchers, what happens, for example, when patients switch from one regime or one type of steroids to the other. And this is just some picture showing that when we switch from prednisolone to the Flazacort, probably there is some improvement in terms of behavioral changes that are, mildly reported or never reported, as you see here. Height restriction, of course, can become bigger problems if we switch from the prednisolone to the Flazacort, but weight gain, as we see from this data, can possibly improve a little bit. You see here that after switching to the Flazacort, the number of patients where this was mildly reported as a problem was higher compared to before. What happens if we switch from intermittent to daily? We can see some trend in improving the appetite, or in worsening the appetite, or the Cushingoid aspect on weight gain when we switch to daily. So this is something to bear in mind, especially, and to monitor when we discuss this with families. And this is a last slide to show the clinical variability, of course, in patients with different genetic mutation, because we know that, for example, the patients amenable for skipping exon 44 have a better outcome than those on who are skippable for exon 53, for example, or exon 51. So this is also something that we should consider. And there are also some studies on some genetic modifiers that are associated with a better outcome. So in conclusion, it's very important to adapt the approach to this condition depending on the age and the stage of the disease, and to involve all the key professionals, and also to adjust our management according to the occurrence of the other comorbidities that we see in these patients, because this can really change their natural history and their quality of life. I'll stop sharing here. I'm happy to take any question now for this section.
Дякую, шановний пане професор, за таку чудову доповідь.
Thank you so much, dear professor, for your informative speech. It really is interesting to look at the researches of the efficacy of the Flazacort in contrast to prednisolone. We know that it's a very sensitive topic for the patient because the side effect of hormones is quite evident, and the parents very often in Ukraine are scared to take these medications when they read about different side effects. That's why your speech is really very useful for our audience. So I have a question here. Could you tell us, please, is the Flazacort widely used in the UK? Because I spoke with one of the colleagues, and that colleague chooses prednisolone. Do you also have some problems or, specifics of the introduction of new medications?
So the Flazacort is off-label, of course. It's not like regularly approved for the treatment of Duchenne, but we can prescribe it, and usually we don't have, now in 2022, we don't have any problem in prescribing it. In the past, I know that this was much more difficult, but at the moment, it's not a main problem.
Добре, дякую. Скажіть, будь ласка, а який середній вік встановлений?
Okay, thank you. What is the average age of Duchenne diagnosis in the UK? At what age does it get diagnosed on average, if there is this information?
From the most recent data that we have, it is about around 4 years, 4 years and a half at the moment, as a mean.
Добре, дякую. Колеги, чи є запитання до
Okay,
професора?
thank you. Dear colleagues, do you have questions to Professor?
Якщо є можливість, підключайтеся.
Please raise your hand, if so.
Ну,
Я бачу Маріна. Ось, не знаю, як прізвище Маріна, піднята рука. Будь
I
ласка.
see Marina has raised her hand.
ну, я бачу, шановний професор, немає нас.
I can't hear the translation. There is no translation.
Marina is one of the interpreters. She didn't have a
Oh.
question. She is asking for the rights to interpret. Sorry.
Чи є проблеми з перекладом зараз, чи все добре? Я так і не зрозуміла.
Now, can you hear the translation?
Now, yes.
Sorry, we have some problems with translation.
Sorry, we had a problem.
Just a moment.
Yeah. There was a question that I didn't understand.
Дякую. Ага.
Uh-huh. Which was the question?
Добре, дякую, шановний професор.
Thank you very much, Professor. Yes, indeed, your speech was very interesting, especially the efficacy of the deflagrazacon and its influence on the child, because indeed we need to help our patients, but also not do harm. So I was very interested personally, especially your last several slides when you showed the difference between the efficiency of various methods of therapy. Thank you. I would like to ask the similar question regarding virology. Are there any trials in UK with other patients that take vamorolone, and what is the attitude of physicians to this medication? Are there hopes that this medication will be a good alternative to corticosteroids such as prednisolone and deflazacort?
So my next presentation will mention also vamorolone. So I will tell you something. At the moment, what I can say is that there is quite a lot of expectations, of course, because you will see, some of the positive results. Actually, we are having, because now it's, there are the 4-DMD results, there are the vamorolone results. So we have planned a meeting, a national meeting in early next year to try to brainstorm what to do now, what to do next, try to having a sort of more homogeneous approach, and also to see which could be, the space for these other steroids like vamorolone. Because of course, in some cases, particularly for the side effects, there might be a lot of desire to have something different. But on the other ways, if patients are doing well on the other steroids, probably it will be a little bit difficult to leave, what is certain for the uncertain. So we will see. But I will show you in some of the results from the trial where we were involved and we recruited some patients in the UK, in our center, and I will show to you some of the results.
Прошу, будь ласка.
We will be very, very thankful.
So if I can share this slide, yes. So this second part will be mainly to share with you some updates about clinical trial and the research of a possible treatment for Duchenne muscular dystrophy. I think that you have had already earlier on today a presentation on gene therapy. It essentially, what this picture shows that we can divide all these approaches into different groups. You know, the ones that try to restore the dystrophin protein, and the ones who try to limit the progression of the dystrophic process, either by preventing muscle necrosis and fibrosis or increasing muscle regeneration. And looking at the genetic approaches, this is the very long gene of dystrophin, which encompasses 79 exons, as you can see here, one of the longest in our body. And we know that Duchenne is caused by a deletion, duplication, or mutation that essentially disrupt the reading frame of the dystrophin gene and lead to out of frame, cause out of frame of the reading, this reading frame, and those the dystrophin protein is absent in muscles. But because the Becker muscular dystrophy is a milder form, at least in terms of the muscle pathology, because in Becker muscular dystrophy, there are in-frame deletion or mutation that somehow allow the production of some levels of dystrophins in the muscle. Of course, one of the initial question was, can we try to transform or to convert a Duchenne boy into a Becker that has a milder clinical presentation? And one of the very first approaches that was tempted was the exon skipping strategy that essentially use antisense oligonucleotides that are very short sequence of oligonucleotides that essentially use the Watson and Crick base pairing rule by linking to the pre-mRNA, and as you will see, preventing some of the exons by being read from the machinery of the cells. So, for example, if we look at these 79 exons that compose the dystrophin gene, and you have a child who has a deletion between exon 47 and exon 51, of course, this leads to an out of frame. But if we try to skip or to jump this exon, and we try to link exon 46 with 52, this is what is called exon skipping, the reading frame of dystrophin can be restored, similar to what happens in Becker muscular dystrophy, essentially. These are here circled, the most commonly used, commonly investigated exon in clinical trial. And you see here a table that summarizes different antisense oligonucleotide exon skipping strategies that are currently under investigations. Some of these, especially eteplirsen, casimersen, golodirsen, have been approved in America, in the US, by FDA, while others are still under investigation. We have also now Viltolarsen, that is an exon skipping for exon 53. And you see here also other companies are developing a similar strategy. And you see here the data from the eteplirsen, for example, for exon skipping 51, and these are 5 years follow-up. You see that patients remain ambulant for much longer compared to the natural history. So these are data from control age-matched patients from the Synergy network in the US. And you see here also that the decline in the forced vital capacity, so the respiratory function, is also less pronounced compared to what happens in the untreated population, as you see here on the right side of this graph. And this is also similar data on golodirsen for exon 53, the 3-year data, in which it is shown the lower decline on the 6-minute walk test compared to matched natural history controls. And these are patients still ambulant after 3 years on the medication compared to what happens in the natural history of the disease. So really promising data. Exon skipping altogether can target nearly 70% of the deleted patients. So this is really a strategy that, of course, is under investigation, because it could apply to many patients, and they are quite safe, honestly, so far. Some of the companies are trying to improve the biodistribution of the drug, because of course this requires weekly administration. Now we have some trials in which the patients come once a month because they are slightly improved, modified to improve the uptake into the muscle cells. So even monthly infusion are good instead of the weekly infusion. And of course, this can reduce the burden for the families and for the patients. In terms of regulations, as you see here, there are different approaches. For example, in the US, the FDA accepts restoration of dystrophin on muscle biopsy as a surrogate endpoint to demonstrate the effects of this medication, while in Europe, they want a more clinical endpoint. So they want to see a clearer clinical benefits to patients, and also they want to wait phase 3 studies with placebo arm. Another approach is ataluren for nonsense mutation that essentially improved the read-through at the ribosomal level to improve the functioning of the dystrophin protein. This is approved from EMA for patients with point mutations that lead to stop codon, so nonsense mutations, and is currently approved under a managed access agreement in the UK. So there will be shortly a review. The data on the long term show some promising results, but of course it's not always easy to have a comparators from natural history database for these patients. I think that you have already heard earlier on about gene therapy, and you know that, of course, different companies are pursuing these, but there is also additional work on the other aspect that is more related to limiting the progression of the dystrophic process. And we know that these corticosteroids act by reducing the inflammatory response and the immune response that on the long term lead to the fat replacement, to the damaged muscles where the dystrophin is lacking. And vamorolone was a steroid-like medication that was developed to reduce the mineralocorticoid effects, thus possibly limiting the side effects related to corticosteroids. And this was the Vision DMD, that is the study that included essentially patients that were either on placebo or on prednisone for 6 months, or on vamorolone, either the low dose of 2 milligrams or the higher dose of 6 milligrams for 6 months, as I said. And then after a washout period of 4 weeks, all patients switched either to vamorolone, the low dose, or vamorolone, the high dose, 6 milligrams, for additional 20 weeks. And we now have the data, the results, in terms of efficacy. This is the time to stand velocity, which was the primary endpoint. And you see that the vamorolone high dose, so the 6 milligram, was achieved at the primary endpoint after 24 weeks compared to placebo. So the study met the primary endpoint. You see here in terms of other clinical endpoint, for example, the 6-minute walk test, the time to walk or to run velocity, and the time to climb, the North Star score. And you see that essentially in all of them, of course, the vamorolone compared to the placebo achieved all these endpoints. This is the difference between vamorolone 6 milligrams and prednisolone, because of course prednisolone is the main benchmark, you know, in this clinical trial. And you see that essentially at the end of the study, if we consider all the data altogether, they are quite similar. There is some mild difference probably in some of this, but we can say that in terms of efficacy, vamorolone is similar to prednisolone. This 2 milligrams probably is slightly less effective. You see here, you know, it's less if the 0 is what is the results for prednisolone, and is the comparator. So let's say that 6 milligrams compared to the 2 milligrams is as effective as prednisolone. These are the side effects, the adverse events of special interest. And for example, if we look at the Cushingoid features here, or the behavioral problems, you know, for sure, the vamorolone 2 milligrams experience much less of these side effects. Also, if we look at the weight gain, for some of them also vamorolone patients on 6 milligram had these some of these problems. But in terms of behavior, for example, in red we have the prednisolone. These were much more common in the prednisolone patients compared to those on vamorolone, even vamorolone 6 milligrams. And it's interesting here to look at the switchers. So the patients that were, for example, on prednisolone here for the first 6 months, and then they switched to vamorolone 6 milligrams. And you see, if we look at the behavioral problems, they dropped from 40% to 20%. Cushingoid features, they dropped from 20% to 6.7%, and the same for weight gain. So there seems to be some positive effect also for those patients who switch from prednisolone to vamorolone in the second part of the study. So in conclusion, in terms of efficacy, they are quite comparable, but possibly the safety profile might be slightly better for vamorolone. There is the possibility to reduce to 2 milligrams, especially if the patients experience additional side effects. One important thing is the adrenal suppression. We know that also patients on vamorolone can be at risk of adrenal suppression, because at the end of the study, we performed the synactin test, and many of them were in cortisol suppressed. So it's very important to alert the patients that this can happen. But for the rest, you know, also in terms of biochemistry, hematology, there were no main issues. Another trial that has just met the primary endpoint is the givinostat trial, which is HDAC inhibitor, and has also achieved the primary endpoint. So might be something that we will hear about in the next few years. And in conclusion, of course, we need to be very good in making good diagnosis very soon. We need to follow the standard of care and try to improve the management of these patients. But also there is more optimism that some of these treatments can become available in the near future to improve the quality of life of these patients. Thank you. I'm happy to take any questions you may have. So going back to the question on vamorolone, you see that might be a good alternative. You know what I can tell you, and I think that this is self-explaining somehow. All the patients who participated in the trial were switched to compassionate use. So the company is continuing to provide the medication for free to these patients who were in the trial. And all of them wanted to continue to take vamorolone. None of them wanted to go to the other two steroids, either deflazacort or prednisolone. So I think that this already speaks about the fact that the families, you know, are happy to be on vamorolone. They are very concerned about, you know, steroids and the side effects. Having said that, of course, especially in terms of weight gain, we were expecting a little bit more because we have seen, unfortunately, weight gain also with vamorolone patients on 6 milligrams, as we see normally with prednisolone or deflazacort, but not all of them. So something that we need to bear in mind. Definitely, the patients grow taller. They don't have the stunt in height that we see in patients, especially with deflazacort. And we know that for teenagers, this is very important because when we speak with our teenager patients, you know, they say, I don't care, I don't want to be, you know, bullied because I'm short, I'm little. It's very important for their self-esteem, you know, the perception of their body. So even, you know, these aspects might be important to consider when we pros and cons for certain treatments.
Маргарита?
Чи відома,
Маргарита?
яка кількість таких пацієнтів?
Is it known how many patients like that in the UK take vamorolone all the time, constantly?
Yeah, so I don't know the total number. I think around 20 patients at the moment. Between 20 and 25 patients were recruited in the trial, not only in London, you know, in all the UK, and they are still on the compassionate use, and they are still taking vamorolone. And now Santhera, who has bought you know, the rights to commercialize vamorolone, has applied for approval at the FDA, and they are planning to apply also for approval in Europe to use vamorolone.
Скажіть, будь ласка,
Please tell us. We know that neuromuscular center in London is one of the best centers in the world in terms of diagnostics, treatment, and clinical researches in general worldwide. Please tell us, the patients in the UK, do all of them have this link and connection with your neuromuscular center in the UK? I mean, are all patients registered in your neuromuscular center, or are there separate hospitals in other parts of the UK and the patients of these centers never come to your center, and there is a separate treatment in separate hospitals?
So there are like 23, 25 neuromuscular centers in the UK, and we try to distribute the patients according to their location to their closest neuromuscular centers. We don't want patients to travel long distances because it's not safe for them. But also we try, you know, to ensure that they can receive the best care locally. instead of needing to travel several hours to achieve another center. What may happen sometimes is that, for example, not all the centers may have a neuromuscular physiotherapist who is trained for neuromuscular, or a cardiologist, or an orthopedic surgeon. So sometimes we accept joint management, so that, for example, patients come to us, let's say once a year, for a general review and also to discuss specific topics. So, for example, surgery or respiratory care or anything else, or or physiotherapies, if this is not available in their local neuromuscular centers. But they try to come for specific queries, you know, and sometimes we see them only ad hoc, like occasionally, like for single consultations, if they have specific queries, and then they go back to their local centers. Sometimes they come only for the clinical trials, because we have a database in which all the families in the UK can register to say, I would like to be part of a clinical trial, if there is any, and we can call them, even if they are not our patients. They are registered in the database, and we have a random extraction, so they can be picked up and selected to come to our center for the clinical trial.
Дякую. І ще я хочу додати таке, що у нас уже
Also, I want to ask the following. In March 2022,
ще були заплановані декілька
in March 2022, clinical researches in Kharkiv were planned, and
Also, we had several clinical trials scheduled for other clinics in Ukraine, but since due to the war, everything stopped. But we have a lot of physicians who want to acquire more knowledge in the field of trials and to work with neuromuscle patients, especially Duchenne disease. And we have parents who are ready to ensure that their child will participate in clinical trials. I would like you to take this to account and look on such an opportunity of training Ukrainian physicians in your neuromuscular center to be partners. And in turn, parents also are ready to go to any country so that someone will help their children.
Yeah, that would be very, very important and very interesting, actually. Yeah, we try to do the same also for other conditions, you know, because I think that it's very important to involve several countries in the clinical trials, because hopefully there will be many available, especially using similar approaches from different companies, you know. So it might be that we don't have the capacity in our country to take on all the clinical trials. So this is why it's very important to distribute and involve other countries. But to do that, of course, it's very important to build up the capacity in the centers to run clinical trials, you know, because you need trained clinicians, trained physiotherapists, you need to have dedicated administrative support, because you have to upload the data into an electronic form that goes to the central lab. So it's very important to work on this. And it would be fantastic, you know, if this is something that can be realized in the future. And definitely, you know, we will be happy to assist and support the training of the centers to say what you need, what you would require, you know, to run a clinical trial and so on.
Дуже дякую за
Thank you very much for accepting our invitation. Thank you very much for taking part in the conference. Oksana, the floor is yours.
Thank you.
very much,
Thank you.
Professor
Thank you for
Barnella.
inviting me. Have a lovely rest of the day.
Дякую. І ми продовжуємо
Thank you, and we continue our conference. I would like to invite Professor Olena Riva, and the name of the speech is the problem issues of providing palliative aid to the patients with Duchenne disease. Is the professor in touch? We have the video recording of her lecture. She already did it in advance in order to avoid any
Everyone,
problems.
it's a great pleasure to be a participant of this conference as a speaker. And I would like to tell that now I am present in Kharkiv. And 1 year ago, we created a regional Kharkiv program for pediatrics palliative care. And in Ukraine, the pediatrics palliative care is in development, and about before, in previous war period, about 500 and 700 children need in this kind of support. 1 year ago, we created the volunteer group for family with boys with DMD. In our volunteer group, we include the physical therapist, ergotherapist, some medical specialists. For what reason we made it? Because we understand that our medical society don't know about evidence-based approach for treatment and supporting of this family, and we start to create a volunteer group about this family, and some families we supported by Zoom, by virtual, in other regions of Ukraine. I would like to tell that there is a young boy, George. He lives in Kharkiv and now, and this boy has body weight more than 100 kg, and he has a mother and grandma in age 65 plus, and he has no any social support about psychosocial support, about working, about young men needs, and with cooperation of parental organization of DMD in Ukraine, we create the respiratory mechanical ventilation support and other supports for this boy. During bombing in Kharkiv, George was afraid, but we understand that many people were refugees, and we continue to support him. He lives in 4th floor, and unfortunately he had no opportunity to be in Selin during bombing. 24 February destroyed all medical logistic in Ukraine, especially in our region, and as many families with DMD, with boys with DMD, were refugees. Many families stay in Kharkiv, and some families were in occupied territory by Russian army, and we know that some boys and family has no approach to the medicine, pharmacy, sometimes food, and now we destroyed connection with this family. Our vision of the difficulties in preview period, not only in pediatrics palliative care, and of course in, for example, in approach for DMD treatment, and first of all, it's acute storage qualified medical personnel, insufficiency of educational programs and lack of opportunities to study best practice in this field in native Ukrainian language, inadequacy of coordination between primary, secondary, tertiary levels of medical care, and of course, no coordination between social support and medical support. No any interdisciplinary coordination. Absence of the state of policy in pediatrics palliative care, and no any programs and monitoring, and of course, as example, there is some problem about nutritional. We know that there is a European Society of Pediatrics, Gastroenterology, Hematology, and Nutrition guidelines for nutritional support of patients with neurological impairments, especially DMD. But now we have massive humanitarian aid availability, various clinical nutrition formulas, but we have no opportunity to put gastrostomy, and our personal staff, medical staff, don't know about prescribing of this clinical nutritional. It's a lack, for example, it's a small example about educational. Of course, we have no any calculation of pediatrics palliative care needs before war, and now it's impossible due to refugees, due to situation of humanitarian crisis, and we have no any basic educational program, and have no specialist in pediatrics palliative care for families who have children with life-limiting and life-threatening diseases. Our country is in Russian aggression now, and of course, we have society no English speaking. I would like to show you our search from Google about some key words: palliative care in war, palliative care in humanitarian crisis, but there are no any document, no any guidelines for such in Ukrainian language. That's why it's also difficult to support some families. Our vision in post-war period, of course, we hope on victory because many countries support us, and of course, first of all, we may create regulatory legislative framework. We must create coordination centers, departments of palliative medicine in medical colleges, in universities, and of course, some programs must be in developmental and networking. Creation a system of reimbursement of the cost of medicine and medical devices. Creation a system of financing and monitoring of this financing as fundraising, for example, some government support, and we must start educate medical staff of basic principle of pediatrics palliative center. Of course, some educational problems must be as concealed because integration, we need integration in progressive countries in cooperation with international care, pediatrics, children network, pool chairs, other medical societies in palliative care. We need, for example, in educational program, we need in advocacy of specialists in pediatrics palliative care and translation some guidelines, the textbooks in the pre-graduated and post-graduated level. Of course, creation of new international programs in humanitarian crisis of palliative care and perform the monitoring group in our country. Thank you very much for my report, and I think our vision helps for supporting of patient with DMD that needs not only in medicine, but they needs in multidisciplinary team and especially in psychosocial support. Thank you very much.
Дякую, шановна пані Олена.
Thank you very much, dear Mr. Lena. If you are online right now, we cannot see you. Are you with us? Probably there are some connection issues. I don't see her here on the list, so if there are any questions to the speaker, please write them to the chat and we will address all the questions to Professor Olena.
Ну і ми також
And we also invite the next speaker, Jenny Treaty from UK. She will present to us the experience of volunteers' work and cooperation with local government authorities, which is very important experience for our country as well.
Thank you. And thank you, Margarita, for asking me to join you all here today. I have to say I'm completely in awe of the work that you guys do. It's incredible. It's not a subject I know very much about. I hope that what I say can be of some interest to you. I think Margarita was thinking that there might be some learning or some ideas about how we work that people might find interesting. It is something that's very different, and of course where we are is a very different place to where you are at the moment, and my thoughts are with you all. So I don't know how much you know. We're a very small charity. We are in an area in the United Kingdom, in Surrey, which is quite a mixed area. There is quite a lot of resource, quite a lot of people who are able to help others and who want to do that and are able to do that. There's also quite a lot of need, people that need help. And recently, of course, quite a few more than we're used to, with a lot of people coming in particular from Ukraine. Margarita, is it okay for me to just speak in English like this? Is this? There's no interpretation? No, okay, I'll carry on.
Так, у нас є перекладач.
Yeah,
We have interpreting, you can speak English.
We were formed about 7-8 years ago. We were a group of local people and we heard what was happening in Syria, and that people were leaving their home, that they needed somewhere safe to go. A group of us got together with a wish to do something. We weren't quite sure what we were going to do or how we were going to do it. What we started off doing was really actually campaigning, saying we wanted people to be able to come. You know, it wasn't uncontroversial. Some people didn't feel that way, but then also doing very practical things. So when some families did start arriving, doing things like helping people with furniture, helping people to learn English, and gradually we grew. So the scope of what we were doing grew. We got to know other families, other people who had arrived from different places all over the world. And it was never about how they came or where they come from. It was just about the fact that they were here and that they needed somebody to give them some support. So we did things like small grants of money, homework helpers to go and help children learn, catch up their studies. They often came quite behind, needing a bit of extra help. Some language tuition, so one-to-one volunteers, bits of, again, sort of bits of furniture, and also understanding how life works here in the UK, which is quite different to a lot of the places where people are coming from. Paperwork, bureaucracy can be quite complicated, and often people need somebody to help them with that. So that was fairly steady until about 18 months ago, when we were joined by quite a lot of people from Afghanistan, and then recently, obviously, people from Ukraine. So that's been quite a sudden and unexpected growth. We now have 120 volunteers. Our youngest volunteer is 13 and our oldest is 96. And for pretty much everybody that wants to be involved, there's something amazing that they can do, and that working together we can do together. So it's really about working as a community, about everybody being part of the team and people being enabled to give what they're able to give, and that's what we try and do together. I think Margarita wanted me to talk as well about how we work with the local council, which is an important part of what we do, because I don't know how familiar you are with how the UK is governed, but a lot of the official responsibility for some of the work that we do is with them. So it's really very important that we have a good partnership and work with them. And that's something that's been particularly helpful recently with the arrival of Ukrainians, because they were able to fund some posts for Ukrainians who are currently in the community and who are able to now work full-time supporting other Ukrainians as they begin their journey here. So that's something that I found helpful. You know, it's not always straightforward. I don't think it ever is working with anybody, but I think it's an important part of how we do things. So I think, you know, working obviously recently, we've got to know some incredible families, and obviously Margarita's is one of them. It's been amazing to meet her and her daughter, and I think her son-in-law has just arrived, and her young son, of course, Daniel, who is an incredible example to all of us. And I think it's a small story of one of the things that we've managed to do. So we have 2 volunteers working with the family. One is a young man called Theo, who's I think done a lot of traveling in his time, and he's enjoyed showing them around. So he's taken them to Hampton Court, which I think Daniel was very interested in, and not sure where else they've been, but there's been some interesting cultural excursions. And then there's a lady called Sarah who helps Margarita with language lessons. I think her English is pretty good, but there's always a room, you know, to be better. And then there's Irina, who's one of our support workers, who has been helping with all sorts of things recently, particularly to do with housing and other difficulties. And then we have a local hub, which we set up, which is run by some other amazing volunteers, where they go, other Ukrainians go, they get general support, information, connection with each other. We've had some amazing Christmas events recently, a visit to a local park, Father Christmas, which is very, I don't know whether that's a Ukrainian thing, but funny man dressed in red comes and gives presents at Christmas. So that's been happening at the hubs recently. So I think that's a sort of a small story, one family, but it's about how hopefully it's made a difference to them, and it's made a difference to all of us being able to do it. And we always say, as volunteers, as people who are part of Elmbridge Can, it always does, it's done, you know, as much for us as a community as it does for the people that we work with. We learn a huge amount from them, we learn about ourselves, we learn about each other, and it gives our lives, you know, a huge amount of connection and meaning that we wouldn't have otherwise. So we're very grateful really to the people that we work with for that, and for the team that we're part of. So I hope that's interesting in some ways. I know it's a little bit of a different subject to I feel the main focus of the conference, but it's a real honor to be invited to be part of it. So thank you very much. Thank you.
У мене питання.
I have a question.
Якраз саме в Україні в нас
In Ukraine, actually, we have a problem with local self-government and self-organizing body, because there has to be a certain union or association between citizens and representatives of the government. How do you involve volunteers to your organization? Because all citizens, they are dealing with their own matters, and they all try to work to earn their living, also cope with their families. Where do you find people where do people find free time, and how do you find such volunteers who just dedicate their money, their time, their resources, and they just spend them on working together with you and your team? How do you find those people? Jenny, are you with us?
Я так зрозуміла, щось з перекладом, мабуть, не те.
Jenny, can you turn on the microphone, please?
Добре. Я думаю, що
I think we'll continue. Probably Jenny didn't understand that that was the question. So we give the floor to Steve Wells, who will represent to us the work of the charitable organization. But I would like to say that basically people in UK, starting from school, they are being taught to be involved in charity, and there are many people in the UK who help others who are open. And this should not be just, inherent quality, but this is due to education, upbringing. So, Steve, the floor is yours. Please introduce yourself and tell us a little bit about your organization. Steve?
Sorry, did you want me to speak now?
Так.
Okay.
Yes, Steve, please.
Do you hear translations English? Translation?
I will talk slowly in English, if that's okay.
No, you can talk.
The question, you can,
I will talk English, yes. Trying to.
Так.
Okay, well, like Jeannie, I'm very humbled to hear about the work that you do, and I hope that what I'm going to say now has some relevance. What I will try and do is talk about some of the projects that Elmbridge Can has undertaken, particularly those that have a health and disability dimension to them that will hopefully make it relevant. All the work that we do is in the context of understanding that when people are displaced from their homelands, when they're fleeing terror, and this is particularly true if they're disabled, they are fearful and untrusting, and people lose their confidence. But most of all, they lose a sense of who they are and what is their personal identity, what is the nature of their self after all the trauma they have been through and then faced with a different environment. So in all the projects that we run, all the work that we do with the people we support, we put an initial emphasis on ensuring physical safety and well-being, physical. I mean, if that could involve, for instance, finding a better more functional wheelchair for someone who is has disability, to try and generate some initial sense of trust so that people feel they are welcome, that they are amongst friends, fellow human beings who are there to help, and that they are people that they can trust. And it's from this starting point that we try to facilitate activities which will re-establish their sense of personal identity, to enable them to feel themselves again in a completely new and different environment. In all this, what we try to do is enable them to forge, to create what might be called sensory connections with things that they are familiar with the effect of reuniting body and mind, which can have been separated by all the trauma that people have gone through, and a sense of reuniting them with other people. So what do we do? One example of what we do is when people arrive, we give them an opportunity to try and grow their own food or to grow flowers, growing plants. One of the early families that we helped was from Syria, and I asked the dad when he arrived, what did he enjoy doing? And he said, in Syria, my dad and I grew our own food. So we immediately found him a plot of land and helped him clear it. We gave him seeds and plants, and he produced the most wonderful environment, a wonderful plot of land growing great food, some of which I'd never seen before, that he was able to grow from the Middle East. And he was at great peace at this plot of land where he grew, he still does, grows his own plants. And I remember once being with him amongst all his plants, and I said to him, what do you enjoy about this? And he said, when I have bad thoughts, and this man had been through the most terrible trauma of being physically bombed in Syria and spending time in a refugee camp, he said, when I come here and I have bad thoughts about the past, I feel that those thoughts in my head go through and down my body and into the ground. And in the ground, something happens, and those thoughts come up and are changed, and they're plants, they're food. And that was wonderful. And he came there with his family to do that. So that was a wonderful sense of he was getting energy and peace by feeling rooted in a new environment. And that was profound for him. Other things we do is provide bicycles, which enables people to get around the local community, or helping them walking, or walking with them if they are disabled. And that, again, is taking energy from their surroundings, which helps reforge that connection between what is sensory and what is going on in their minds. And in that, they re-establish themselves. Cooking food together is another example, which is highly sensory. And of course, it relates back to their own cultural heritage of what they have done through their lives. Sewing and knitting, and we don't just limit it to women, although I haven't had many men who've taken up sewing and knitting, but that would be an example. Yoga and Pilates are other examples of where people are getting back in touch physically with their feelings. One-to-one English lessons, again, it's a sense of connection. What we're trying to do is forge reconnections, all those roots that have been pulled up in the trauma of leaving. We're trying to reconnect those roots. And I particularly, as Jeannie was saying earlier, I've been struck by how young people have been able, our young volunteers have been able to work with young people one-to-one. A local school has helped hugely with giving one-to-one instruction. And there's something about the bond between young people where they have less prejudices, less, as we say in English, baggage, and they're able to help young people one-to-one. And simply having fun, enabling children to just forget for a moment what they've been through. So having magic shows for young children has been very helpful after the traumas they've been through, so that not all life is grim. Going to events, having time out of home, whether it's to a local place like Hampton Court that Jeannie mentioned, or going somewhere else to the seaside, to London, all these things help reorientate and give people a sense of who they are themselves. And particularly it's been helpful with the Ukrainian people that we have supported, running seminars for helping them to get into employment with one-to-one advice. So all this is about reconnecting where things had been pulled apart during the traumatic transition from what has been happening at home. So those are some examples of the projects that we've done. You also asked me to talk a little bit about how we can influence local and state decisions. Well, on a local level, we work in partnership with our local area. And here we've learned a lot. What we need to do is to complement each other. So what the charity does complements what the council, the local authority, does. And you need a clear agreement at the outset of this partnership on who does what, because without that, there tends to be conflict and it undermines the development of trust. And that development of trust I talked about earlier is terribly, terribly important, because what war does and the trauma of leaving places is undermine people's trust. And their first instinct is to blame people, to look for the bad guys, when actually what is needed in working in partnership is trust. And so if mistakes are made, the finger of blame isn't pointed at people, but we look for mutual solutions working together. So that is on a local level. Trying to influence national policy, we try to tell stories, a narrative to representatives of national government that will complement facts and figures. So when we talk to representatives of national government, we tend to go with people that we support. We go with them to tell their stories, to affect them emotionally, as well as just presenting them with figures. Because what we're trying to do, and what we're trying to do the whole time in all the work that we do, whether it's with a member of parliament or a national government, or with our volunteers and the people we work with, is to generate empathy so that people can put themselves emotionally in the shoes of the people in front of them, and therefore have an instinct immediately on what their needs are and can support them. So the theme running through what I've said is to generate trust, where trust is in short supply in terms of the implications of conflict, and to try and open up connections on an emotional level, not just on a rational, factual level. I hope that's helpful. I'm very ready to take questions if there are any, and I just hope that had some relevance for your conference.